Sometimes patients only discover they have endometriosis when they are being investigated for infertility because they actually have no pain. And that's the mystery of endometriosis, because some patients have no symptoms and some patients have quite severe symptoms, even though their staging or the extent of their endometriosis may not be extensive. So there's no link between how severe the staging, meaning how much lesions there are, how much scar tissue there is, and the amount of pain, which is another thing that's very interesting and mysterious about endometriosis. So how do we treat endometriosis? Well, we have medications, and you'll have a whole lecture on medications, so I'm not going to get into that. You have surgery. I'll just show you one video. And of course, lifestyle changes. And you've already heard about diet. You're going to hear about stress management. You're going to hear about exercise. This perfectly, and I made this slide before I even saw the program for today, so I'm telling you, we're not in cahoots here. We're on the same page without even talking to each other. What are the SOGC guides? SOGC is our National Association of OBGYNs, and we come out with guidelines on different topics to kind of, we review the literature and we figure out what seems to work based on the literature and how can we advise our colleagues on how to approach a problem. And so the guidelines were published on endometriosis. These ones are the most recent that we have, and they're 2010, and we're about to revise them again. And you can see that when someone has pain from endometriosis, we don't go right away to this, right? There's other steps that can be taken before, which is first-line medical management of the pain. So we don't really need to confirm by laparoscopy if we suspect the diagnosis. And that's a really important point, because some physicians may have, some patients are offered empiric treatment, and that works very well for them. They don't need to have the diagnosis confirmed, even though it's suspected. We try medical therapies. There's first-line and second-line therapies, and if those don't work, or the patient would prefer having a surgery, we can go to surgery. And then if these don't seem to work, that's when we're looking at additional testing or chronic pain management in our multidisciplinary clinic, and I'll talk a bit more about that. I'm a big promoter of suppressing the menstruation because I explained to you how the menstruation, that big inflammatory changes and hormonal changes that occur in the body can affect endometriosis and other conditions. And often, of course, patients with endometriosis will have huge cyclical peaks in their pain, usually at the time of menses or before the menses. And so stopping the menstruation is quite important, and we have numerous tools for that. But a lot of patients feel like maybe it's unnatural or unsafe. And so I just want to reassure you that really it is safe, it's completely reversible, does not affect fertility, and it does protect against certain cancers like ovarian and uterine cancer. The other thing that I often tell my patients is that about 200 years ago, women would go through about 150 menstrual cycles in their life because they would get pregnant in their teens. As soon as they start menstruating, they'd have baby after baby after baby, and they'd pass away early. Like the lifespan was much shorter. So having a period is actually not a natural thing. It's not a normal thing for women to have period after period after period. And that may be part of the reason why we're seeing more and more endometriosis and other types of cancers like ovarian cancer, because the body is going through this constant incredible cycle of preparation, shedding, inflammation, shedding, that it never used to go through, right? I'm not advocating to have 8 babies. I'm just saying. I'm just saying that it's not. Now, that women nowadays, I said 150 nowadays can have up to 450 periods in their lifetime. That's a huge difference. So, is it really natural to have a period? I don't know. So part of the treatment is laparoscopy, and some of you may have had laparoscopy, some of you may not know what it is, so I thought I'd just put a slide up. It's a minimally invasive surgery done through small incisions. It's done under general anesthesia, and it's usually a day surgery, unless a much more extensive procedure is done. So this is a picture in the operating room, the surgeon standing here looking at the camera and working through very small holes in the abdomen. This is what the holes look like. This is my port setup. John's is probably different, but I have 4 ports usually. This is the belly button here, and then lower quadrant and paraumbilical. And the goal of surgery is to remove all the lesions of endometriosis, to restore the normal anatomy, to release adhesions or scar tissue, to remove cysts. And as well, we get into more extensive surgery, for example, with bowel endometriosis if the patient is symptomatic from that. I have a video here of a little surgery. I don't know if it's going to run. I probably have to go. Oh, it's running. I'm so excited. So this is an excision of endometriosis video. And so as you can see, the black lesion is typical powder burn lesion of endometriosis. And this is in the back of the uterus to the right, very typical area where we find endometriosis lesions. So in our center, we use the needle tip cautery. Other surgeons might use scissors. Other surgeons might use lasers. It doesn't matter what the tool is being used. The goal is just to remove the disease. So whether you use, any tool they use to cut is fine. So lasers are not better than scissors. They're not better than needle tip cautery. It's just, I do believe that removing it is better than burning it. So that's my only recommendation, is that I think that endometriosis in general should be excised. But how it's excised is not particularly important. This is a picture of before and after. So this woman had about a 3 centimeter cyst in her left ovary, and then after removal of the cyst. I'm going to talk about a few other conditions that cause pain and that are more common in our population, such as adenomyosis. So adenomyosis is like the cousin of endometriosis, really. What happens is the cells that usually line the lining of the uterus in endometriosis, they wind up outside the uterus. In adenomyosis, they wind up in the muscle wall of the uterus. And that can cause quite severe cramps and very heavy flows as well. Now, it tends to be more common in women who've had babies and common in older age patients, and also after people that have more severe endometriosis. But it's definitely a contributor to pelvic pain. Adhesions. I want to talk about adhesions because many patients do have adhesions, and there's a focus maybe on the adhesion causing pain. And I think it's important to understand that not all adhesions are created equally, and not all adhesions cause pain. So if adhesion is a band of scar tissue after inflammation, but it's more likely to cause pain if it restricts an organ. For example, if it's causing intestinal blockage, like an actual blockage of the passage of food through the intestines, or if it's actually binding down an organ like an ovary that's a very dynamic organ. The ovary changes in size throughout the month, so it ovulates, it gets bigger, and then it releases the egg, it gets smaller. So that organ, if it's restricted or constrained by adhesions, may cause pain. However, you might have something like this. This looks like a lot of adhesions. Look at that, it's full of adhesions. This is fat. It has no sensation. It doesn't matter how many of these you have in your abdomen, it's not going to cause pain. This doesn't look like that many adhesions. Look at a few little brand of adhesions, but this is the ovary buried behind there. So this ovary here, every time it ovulates, will cause pain. So that's the thing with adhesions, is you have to be careful about obsessing about, for patients to look at the adhesions as a constant cause of pain. And the other thing that's important to understand about adhesions is they are formed within 7 days of surgery. So if someone had a surgery 10 years ago, their adhesions were made that week after the surgery. Unless there's a new process of inflammation that's happened, like an infection or an ongoing endometriosis, those adhesions haven't moved and haven't changed. So if you had someone had a gallbladder surgery 10 years ago, the adhesions they have from their gallbladder, they're there, they've been there all that time. They won't suddenly start causing new pain in 10 years down the road. So it's a really important concept to understand. Other conditions we see a lot are interstitial cystitis, or we call it painful bladder syndrome. And patients will have frequency, urgency, frequent voiding at night, and it feels like they have a bladder infection, but every time they get tested, there's nothing, no pathogens, the urine seems clear. And basically that's due to sensitized bladder nerves, as far as we understand. And this is a very often coexisting with endometriosis, and I'll explain why a little bit later. Or it could be on its own. It doesn't mean you have endometriosis if you have painful bladder. It just, sometimes we see it in combination. Irritable bowel, very frequent symptoms we see associated with endometriosis: bloating, pain, change in stool frequency, alternation in constipation and diarrhea. These are the symptoms of irritable bowel. And again, this is an innervation issue. If you do a colonoscopy or investigation of the bowel, imaging of the bowel, it will always look normal. They will never see anything on those investigations because the bowel is normal. It's its function that's abnormal. So it's, the tissue is normal, but the innervation, the function of the bowel is abnormal. And so this is something that you will see in association with endometriosis as well, and I'll explain a little bit later why. Trigger points. Trigger points are little sore points of the muscle fascia area, and they can occur in the pelvic floor, they can occur in the abdominal wall, and they're also very commonly associated with patients with pelvic pain, obviously, and endometriosis. They can be the sole cause of pelvic pain in some patients. Abdominal wall pain, which is again related to trigger points. We see some patients that have clear pain that's, even though they think it's pelvic, when you examine them carefully, it's actually in the abdominal wall. And it can be a thickening of tissue, poor circulation, and the area can be very sensitive just to light touch. Patients say, I know I'm cooking and I just lean on the counter and I have to walk, like just touching the abdomen makes me retract from the counter. Well, that's not your ovary. If your light touch of your abdomen to the counter is making you repel in pain, your ovary hasn't even been touched. So it is your abdominal wall that is tender. And then we have pelvic girdle pain, which is our physiotherapist finds in a lot of our patients, and she finds that it's a more mechanical pain. It's felt more on the front, sides, and back, and that is something that responds quite well to physiotherapy intervention. So do trigger points, by the way. And of course, pelvic floor muscles. So the pelvic floor muscles hold and sustain our organs so that they don't fall out from between our legs as we're walking. And so these muscles have a very important function. They also relax and let the bowel, us evacuate our stool, and relax and let us empty our bladder. And so they're very complicated, very sophisticated muscles, and they're very important to women and men too, but we don't really care about them today. So, and so they can also become quite tense and tender and contribute to pelvic pain. So women with pelvic floor tension have difficulty relaxing these muscles. They have higher pelvic floor tension. They may notice difficulty relaxing the pain and tension that increases also with stress, emotions, and thoughts. So what do we do to reach a diagnosis if we have such a difficult box that we're dealing with, and the access is not easy, and there's so many different organs that can contribute to pain? Well, it becomes super important to get a good history. And so in our clinic, we have online questionnaires that our patients have to answer before they see us, and they are long. It takes them about 20 minutes to half an hour to fill out those questionnaires, but they all do it, and gladly, because they want us to help us figure out what's going on. And then the physical examination is very important. Having an examination that's very discreet and very careful, and really looking at all the potential triggers about abdominal and pelvic. In our clinic, we do an ultrasound guided pain mapping, so we also use the endovaginal ultrasound in women who can tolerate it to kind of reach up a little bit more, and under direct visualization, see if we're touching the ovary on ultrasound, is that tender, we're touching the uterus, we're touching the bladder. It gets us a better sense of where the pain is. And then physiotherapy assessment is also important, because as you can see, muscle, pelvic floor, abdominal wall trigger points, those are all things our physio will help us, identify. As a gynecologist, after doing this for many, many years, I can assess for that to a certain degree, but I still trust my physio more, and I think the physio can also initiate a treatment plan for anything. And then some patients need a laparoscopy. If we think there's an internal trigger related to endometriosis, then of course laparoscopy would be part of the assessment and treatment tool. Now the big $1 million question is why do some patients respond really well to standard treatments? For example, surgery for endometriosis, medications for endometriosis, suppression for irritable bowel, treatments for bladder pain, and some don't. They do great. You treat them the standard treatment, they're fine, the symptoms are better, they might have occasional flares, but they're managing. And then there's other patients that that's not working, their pain is constant, they're not better, and then the pain seems to spread. So it starts in the endometriosis area, next thing you know, the bowel's involved, the bladder's involved, they have trigger points. Why does that happen? Well, that's the process called central sensitization, and this is a really important concept to understand. So our bodies, they all have a pain alarm system, and the pain alarm system consists of nerves, peripheral nerves, which are the sensors, and those nerves detect initial event or injury. Endometriosis would be one example of something that might trigger a nerve to be excited. So when the sensor becomes excited by initial event injury, it sends a signal. It sends a signal that goes up the spinal cord into the brain, and the signal is interpreted by the brain. Now, what's interesting is the brain is not always interpreting the signal in a way that we think would be logical. So there are some very clear signals. You burn yourself, you withdraw, the brain gave an immediate, protective response. That's a very protective mechanism. But there's other times where the brain and the sensation are not in line. Examples, paper cut. I mean, that is like the most awful, painful thing, but and the pain is like, it's you notice it, you know where it is, but is it really dangerous for you? Not really. What about the guy in the army in the war that is fleeing to safety from being attacked and is running and gets to safety, and about 2 hours later when his adrenaline is relaxed, he realizes his arm's been shut off because he hadn't noticed the pain of his arm being shut off. Because why? The brain went, not important, more important to get away from them. Don't pay attention to this right now. This is not going to kill you. They're going to kill you. So get away. And that's been reported numerous times. So as you can see, our brain doesn't always give us an accurate reflection of what's happening in our body. And also, when someone's been in pain for a long time and the pain triggers have been repeatedly activated, then the pain alarm system can become faulty. And that's what can lead to chronic pain. Because the brain can modify the signals by either increasing them or decreasing them. And the factors that can influence how the brain interprets the sensors is mood, stress, environment, past experiences, and the meaning of pain. And so some sensors sometimes peripherally can become overexcited. So for example, a sunburn is a great example of that, because interestingly, our skin sensors do not detect ultraviolet rays, which is what is burning us. So when we're at the beach, having a great time, lying in front of the sun, we're not going, I'm getting burnt right now. We don't know. We're not sensing it, right? 2 hours, 3 hours later that evening, you're like, oh my God, what did I do? Because now I'm red and I'm burnt and it starts hurting. And what's hurting? It's the secondary inflammatory reaction, not the initial injury. So our body, unfortunately, our sensors are not detecting ultraviolet radiation. We're not equipped to detect that. But the inflammation, that we can detect. And what happens when the inflammation occurs in our skin? Wow, that's painful, right? And so if you just touch lightly your skin, it's painful. Is that a normal sensation to be just touching your skin and having tremendous pain? Well, that's not, the normal pain reaction. That's an enhanced reaction of our sensors. So it's a sensitization of our peripheral sensors. They become ultra-sensitive. The same can happen with cross-sensitization. So that's because our brain doesn't have a really accurate map of our body, especially in the pelvis. But a perfect example is brain freeze. You're swallowing something cold, it's in your esophagus, you have a headache. What the hell? How does that happen? So because our brain is not, somehow the sensors from this esophagus, the throat, are somehow linked to something, and that's still a bit of a mystery. People are still working on that one, but it is not the proper local. It should be cold here, but we're feeling it in our head. That doesn't make sense. But the same with the pelvis. There's not a clear map between the pelvis and the brain. So that explains how the pain goes to other organs: bowel, bladder, pelvic muscles, skin, because that sensitization occurs, and then the other organs also become involved in the pain process. There's also a wind-up that happens. So wind-up is what I was mentioning when someone is having repeated episodes of pain. Endometriosis is a perfect example, because monthly there's this, sensory attack, of pain to the pain alarm system. Every month at the period time, the patient or the woman has this pain that the brain has to deal with and deal with and deal with, and eventually the sensors are becoming so sensitive, and the brain has become so overwhelmed by all these pain impulses that it's just like, let's just do pain all the time. Let's just do pain all the time, because I can't deal with this constant pain unless it winds up the pain alarm system. So the bottom line is the pain alarm system becomes faulty. So it doesn't tell us how dangerous the problem is. It doesn't tell us what the problem is, and it doesn't even tell us where the problem is. And that's really the essence of chronic pelvic pain or chronic pain conditions. The good news is it's possible for us to make changes in our pain alarm system. So the sensors are replaced pretty much every second. Pleasure hormones or endorphins can block pain signals. Nerves are very adaptable and can be retrained, and there's a concept called neuroplasticity, which is explains how this happens, meaning that our brain is very plastic and able to change. And actually now they're seeing the changes on imaging of the brain, which is fascinating. They're doing MRI, functional MRI of the brain, and seeing that patients in pain, their gray matter, like parts of their brain, are decreased in certain areas that are quite related to pain. And if you actually reverse the process of pain, if you heal it with other techniques that we'll talk about, the gray matter changes. It comes back to normal. So there's actually now proof, like objective proof of pain, because pain is a subjective experience. It's reported. Pain is only measured by what the patient tells us or pain behavior, but there's never been an actual objective measurement of pain, and now we're close to getting that with the brain imaging. So there's lots of interesting research being done in that area. So we can retrain the brain, and we can enhance the gate control of our spinal cord and our brain to diminish pain and make it less unpleasant, make the sensations less unpleasant. How do we do that? Well, it's not just surgery and medications, but certainly removing the peripheral triggers can help, because if you have constant menstrual pain every month, your pain alarm system is dealing with this cramps from the uterus, it's hard to heal, right? So it's important to remove the peripheral, what we call the peripheral triggers. So stopping menstruation, removing endometriosis if it's part of the pain problem is part of the issue. Dealing with the muscles with the pelvic physiotherapy. But to deal with healing the brain, healing our pain alarm system, that's when we start talking about lifestyle, mindfulness, cognitive behavior therapy, yoga, those kind of things. And you're going to hear about all of those this afternoon. So with that in mind, having spent 15 years with my partner, Christina Williams, seeing pain patients and realizing that surgery and medications, were tools that were useful, but there were limitations to those tools, we lobbied our government and our health authority to get funding for a multidisciplinary clinic. And in 2011, we were successful in getting the funding, and therefore we founded the BC Women's Centre for Pelvic Pain and Endometriosis. It consists of currently 4 gynecologists and a fellow, 1 physiotherapist, 1 counselor, 2 nurses that, they relieve each other. We have clerks, administrators, we have a research coordinator and research trainees, and you can go to our website to look at all our patient resources, what we do, our research, our publications, everything's on the website. This has been a tremendous change for us. It's been a godsend to have people to work with and to work as a collaboration to help our patients. What the program consists of, as you can see, is an overlap of gynecologic assessment, psychological treatment, musculoskeletal treatment, and the overall sensitization treatment. So it starts off with, and we see about 2,000 patient visits a year, so about 600 new patients a year. And unfortunately, because the demand is so grand, we cannot take patients from out of province. So in case you were thinking about hopping a plane or something, I'm sorry, but we won't be able to do that. But I think John's got the right idea in trying to get similar clinic models here, and I would strongly support any kind of lobbying that you can do as patients to help him get that funding. So the program that we have is basically starts with an assessment by the gynecologist. And the gynecologist assessment, I showed you what it was about, the history, physical, ultrasound, pain mapping. And then some of our patients, we think that surgery is definitely the best option. They need the surgery and they may not have all the other associated pains that I talked about. But some of our patients, we feel they really have the sensitization issue. Like another surgery is probably not going to help them. They've probably had numerous surgeries before and they're at the point of where the surgeries really aren't helping. And that's the patient group that we offer the program to. And our program is consisted of a full-day workshop about pain. And pain education, understanding pain, I just gave you like a 5-minute, very Reader's Digest version of understanding pain. But that workshop is a whole day. And we talk about pain, we talk about things that can change pain and mindfulness and pacing and grading and all those wonderful things that can help with dealing with pain. Then our patients are offered 2 to 4 physiotherapy sessions or 2 to 4 counseling sessions. These sessions are not meant to be the be-all and end-all in a sense. It's not like we can treat all the physiotherapy or the muscle issues in 2 to 4 sessions. They're really an assessment by our physiotherapist and a plan. And of course, there's many qualified physiotherapists in the community that can take over the plan and help with the patient. We just don't have the capability of keeping patients for their entire physiotherapy journey, because we wouldn't be allowed to bring other patients in to come through. So really we're an assessment, education, and management plan kind of clinic. And it works well because often, patients when they leave, they understand their pain, they understand what's causing their pain, they understand that we've removed all the peripheral triggers, whether by surgery or medications, and they have an idea of what they need to work on to improve their quality of life and restore their function. They're already well on that path by the time they leave our clinic. But they know it's a path, it's a journey. When you've had 10 years of pain, you can't imagine that 3 months is going to take all the pain away, right? 3 months is the beginning of another journey towards health, towards healing. So it's more like 6 months really by the time they come through the program, but we don't keep patients for years and years because we just wouldn't have room to bring other patients in. So we have a nurse that does what we call case management, so she's the go-to person for our patients if they're having issues, if they're struggling with something. They always can call our nurse. She's there 5 days a week, and she interacts with us as physicians or the physio and the counselor if there's a specific issue that we can help with. And then when the patients have completed the program, we may meet them again as gynecologists and go over the entire program and make a plan of discharge, and usually make a phone call to their referring doctor to discuss where they've come along in their journey and what the plans are for them, and also offer ongoing support to the referring doctor. So if in 6 months the patient has a setback or questions about something, then he can call us, and that way we can also educate the family physicians in the community instead of taking on everything. We want to educate our colleagues to be comfortable with managing pain and managing ongoing treatment, so that when we're on the phone with them, we can actually explain a little bit about what we're doing. So, as I mentioned, the gynecologists do interventions or surgery, medications. Some of the medications are to stop the period, some are to, for example, decrease the peripheral sensitization, some are to reduce the central sensitization. Sometimes we might use medical neuromodulators. Our physiotherapist interventions, well, they address the musculoskeletal problems. They teach patients how to increase their activity levels without flare-ups, restoring normal bowel, bladder function. They treat pelvic girdle, pelvic floor trigger points, and she also uses some needling techniques. And we have a lecture from a physiotherapist today to find out a little bit more about that. Of course, mindfulness and cognitive behavior therapy are a very important component of changing that sensitization, of healing the brain, basically. Because pain is felt in the brain. It's not in your head, but it is in your brain. So that's what you have to think about. So pain is felt without a brain, there is no pain. So you have to heal your brain. And healing your brain requires working on your brain with things like mindfulness and CBT. So it's not all, and I'm a surgeon. This is coming from a surgeon, okay? So just take that with a grain of salt. So if I believe in this, that means there's a lot of evidence for it, and you have to start believing it too. So lifestyle change is also very important. We heard about diet or sleep hygiene is very important because a lot of pain patients have disrupted sleep, and you cannot heal if you're not sleeping. If you are not getting adequate sleep, how will you ever have your brain heal itself, help your brain heal? So sleeping restoration is absolutely crucial. On our website, there's a whole handout on sleep hygiene. There's also a whole handout on nutrition. And so I strongly encourage you to go there and start looking at those things. Patient engagement. So in our clinic, we have a passport, we call it, and we give it to the patient. The patient has all our appointments recorded in there. There's diet, sleep, stress reduction skills in there, and the patient can record their notes and questions and ideas. And we also give them their diagnoses. So we tick these boxes. These are the most common diagnoses that we come across, and I think most of our patients want to know what's going on and what is the diagnosis. And so we give them their diagnoses, and it could be more than one. It could be they have endometriosis, they have irritable bowel, bladder pain, sensitization, depression. These might be the kind of diagnoses that we give, and then here's how we're going to address all those things. But I think the most important message that we convey to our patients is these ones. Your pain is real. Pain doesn't always tell you what's really going on. Pain's not always dangerous. You don't have to fear movement. You can change your pain and improve your quality of life. A daily practice of self-management tools is necessary. Using a mindfulness-based strategy for at least 10 minutes a day to reduce sensitization is important. Multiple factors play a role in chronic pain and need to be addressed. You need to pace yourself, and you need to make a plan for setbacks. We're all a little bit type A. You know, we all want to see immediate results, and we're starting to feel better. Oh, thank God, I'm feeling better. Now I'm going to go shop at Costco and clean my house. Not a good idea. If you want to be in bed for the next 3 days, that's what you do. But so there's this tremendous boom bust that occurs in our pain population, where like finally they have a good day and they're going to go all out and use that good day to get everything done. Not the best way to kind of becoming more and more functional. And our physiotherapist goes over that in very, a lot of detail and about the pacing. So how do you break the cycle? Well, you need to learn and understand about chronic pain. That's why I'm so happy to see you here today, because this is the first step to really healing, is to understanding. Practicing mindfulness, anti-inflammatory diet, restoring sleep, positive self-talk, self-compassion, addressing bowel and bladder issues, using techniques to decrease muscle tension, practicing movement and stretches that are safe and rebalance the body, increasing activity gradually, pacing and grading. And then the most important is get information about how your body works before living with years of suffering. Find out what is hurting and find solutions. Target the teens, because this whole process of chronic pain starts with this recurrent episodes of severe cramps in teenage years that for some reason some physicians allowed, or even parents allow it happening, because often, well, I had cramps as a teenager, so it's normal to have cramps. And so I don't think it is, not all women that have bad cramps will develop chronic pain. Don't get me wrong, it's not what I'm saying. But if you have other predisposing factors to chronic pain, having that recurrent episode of severe pain is not a good idea. Work together with your doctor in supporting family and friends, and reach out and share with other women. This is what this is about today. These are references and resources. I highly recommend you read the book by Neil Pearson, who's a physiotherapist, Overcome Pain, Live Well Again. He uses very, very clear language to explain the sensitization concept. All these are on our website, by the way, so if you Google BC Women's Centre for Pelvic Pain, you will find our website. You go under patient resources. There's videos, that we made. We have to remake them, I can't stand looking at them anymore. But anyway, there's videos about medical therapies for endometriosis, chronic pain. All the books are there. Lots of handouts. So really good place to start. There's some online pain management. The UVic, for example, has an online pain management series that you actually don't have to go in person. You can do it online, but we have groups all over BC. Of course, that doesn't apply to you, but it's still a resource that you can tap into, because you don't have to attend a group. You can do it online, have support through the online as well. There's numerous options and supports out there. So I just want to thank you for your attention, and this is my favorite picture of my children, because they got into the bathroom and found the stickers. As a gynecologist, I thought that was pretty cute. And of course, this is an old picture, because I just sent my son off to university. So.
So we do have time for some questions.
You said that excision is better than ablation. So what happens when you undergo ablation?
Oh, I don't think it's harmful to undergo ablation, and I think for superficial endometriosis, if it's there's different stages of endometriosis. So stage 1 would be the very superficial lesions, and they probably are treated fine with ablation. It's more when you have deeper lesions that I can show, that the black ones that are a little bit deeper, they're maybe 3 or 4 millimeters deep. If they just get burnt on the surface, they might not be fully treated. They may not get the full lesion. It's just, for me, there's two reasons I like excision, because deeper lesions. Secondly, I like to have the diagnosis, because if a patient has had laparoscopy after laparoscopy where they had 3 lesions of endometriosis cauterized and no pathology, so no proof that it was endometriosis, then they may not even have endometriosis. But some lesions that look like endometriosis, that are the more atypical appearance, may not be endometriosis. So I like to know that the diagnosis is the diagnosis. Not that it really changes what I'm going to do with the patient, because often the pain is beyond that. It's not about endometriosis anymore, it's about sensitization. So it doesn't mean I'm going to go back and reoperate because they left one spot of endometriosis, right? It's just that often the label of endometriosis creates a lot of anxiety, right? About fertility, about all sorts of things. And so that label I don't want to give lightly. So I like to know that if I take a piece of something out, a tissue, and I have the pathologist look at it and he's told me it is endometriosis, then I can feel confident telling patient you do have endometriosis. But it may still be that most of her problem is in the, irritable bowel, or, it could be other things that's going on. But I like to know that the diagnosis is correct as well. Yeah.
Is endometriosis hereditary?
There is a hereditary component to endometriosis. It's not like every mother that has endo will have children that have endo, but there is an increased incidence if you have a first-degree relative. So if you have a mother that has endometriosis, it's about 3 to 7 times more likely that you'll have endometriosis. And there is certainly a lot of work being done on the genetics of endometriosis, and there's some genes that have been identified that are more common in endometriosis patients. But it's probably a multifactorial polygenetic inheritance, not like how certain genetic diseases are like you're passed down like one, or either you have it or you don't, 50%. That's not that kind of genetic disease.
I'm just wondering, I had a continued hysterectomy and hysterectomy last year, and like my pain has gotten way worse since then. But we haven't done any, like, other than trigger point therapies, we haven't done anything else. Well, I go to physiotherapy, I go to pelvic floor therapy, I go to like a psychologist, I do all of those things, but I haven't been able to work for a really long time. Would it be beneficial to get a scope done one more time just to see if maybe there is something still there or something that's came back? Because I do take estrogen for my menopause, so I've only ever had one scope done, and then the hysterectomy was next. So it's not like I've had a ton of surgeries. I've only really had 2.
Yeah.
So would that be something to talk over with my doctor?
You can just, I think that the key is the physical exam and really like trying to figure out where the pain is, because in my mind, if everything's hurting from your belly button down to your upper thigh internally as well, like I tell my patients, I can't go and cut this part of your body out. I can't do that, right? So it really depends what's felt and where the pain is. So in my mind, if I examine a patient, I feel one spot that's super tender, and that's where all their pain is, then I'm more likely to go and operate looking for that spot, right? Thinking, okay, there is a trigger there. There's something very localized there. It could be their muscle though, so I make sure my physio assesses and all that.
Yeah.
Are you taking progesterone as well, or just estrogen? So you're taking both. Okay.
Yeah.
So, and the fact that it got worse after surgery is interesting because there is a lot of literature now on estrogen effects on pain, chronic pain. So sensitization is a brain problem, right?
Yeah.
And our brain is very sensitive to hormones as well as the rest of our body. And there has been some evidence that drops in estrogen make pain worse.
Okay.
So you have less estrogen than you used to because you're on hormone replacement therapy. And so it's possible the worsening of your pain could be from that. It also could be from the surgical trauma. So your tissues got operated on, and that creates irritation at the peripheral area. It doesn't mean that there's damage or that anything bad was done to you in terms of the surgery, but you had a surgical procedure which irritates nerves, right? So there's a number of other reasons why you might still have pain other than endometriosis still being there. So I think that's an important question to ask your doctor.
Yeah, because I'm just wondering, because it's been well over a year now, and I have been in physio and pelvic floor therapy for quite some time now, and my pain is localized to 2 specific spots. And
well, then it's worth discussing with your doctor maybe, and also the mindfulness part. Have you been doing any cognitive stuff, mindfulness-based therapy? Calming the brain down from that point of view, that's really important too.
Yeah.
Can you comment on sort of what she had mentioned about hysterectomies as a solution to that? Just because I feel terrible for you, because I think a lot of people would see that as maybe a final straw or something, a solution to it. And obviously I've heard cases where that's not the case.
Correct. So it's hysterectomy for chronic pelvic pain is not always successful because if you ignore all the other factors that I've presented, right? If your pain is only cramps at your period and you have debilitating cramps at your period time and the rest of the month you can manage, there's not that much pain, hysterectomy will likely make that pain better, right? But if you have pain throughout the month all the time and it's localized in your pelvis, you can't blame the uterus for everything, I'm sorry. You just can't. So you have to really be careful. Be careful about what you're trying to accomplish with hysterectomy, okay? Hysterectomy helps with menstrual cramps 100% of the time. That's all I can say about that. Yeah.
Thanks, Dr. Allaire. That was a superb presentation. I wonder if you can comment in your clinic, who does the medication provision? Who prescribes the medication? To your gynecologist or do you have?
Yeah, so that's a really good question because you must be talking about the opioid because we used to get, interesting, when we started practice, Christine and I, when we were in practice, in the early days, we used to see patients come to us on a lot of narcotics, right? And we had a huge issue with narcotic management, so we actually invited a pain specialist to work with us to deal with narcotic management, weaning patients off narcotics, or even just getting the right concoction, because they're often on multiple medications, narcotics, gabapentin, antidepressants, anxiolytics. They were on a whole, and so we felt a little beyond our depth in that, and we didn't think we were the best people to address that. So we did invite different physicians to come, or we worked in consultation with a polypharmacist that would help us in the more complicated cases. But in the last 3 years, we were just talking about this the other day, we noticed a huge shift in that patients do not come to us on narcotics nearly as much as they used to, because the college, number one, has cracked down quite a bit on narcotic use, but rightly so, because you know what? Pelvic pain is a visceral pain condition. It's a visceral, meaning visceral means the organs inside, right? So visceral pain is not really well treated with narcotics, because narcotics mess up your bowel function, they mess up your brain, they may make your brain more sensitive to pain. So treating that kind of pain with narcotics is often just spiraling patients down into more and more narcotic use. And so we actually try and keep patients off narcotics now. And because they don't seem to come to us as polypharmacy, like as many medications, we've actually been able now to do it on our own. So we don't really use anymore. If there's a really complicated one with a lot of maybe psychiatric medications that we're not that comfortable, we might consult with our psychiatrist, but not as much as we used to.
What are neuromodulators and who prescribes them?
So neuromodulators is basically like a broad term to indicate medications that affect the central nervous system and our pain alarm system. So basically to try and calm down the hyperactivity of either the peripheral nerves or the central nerves. So there's different categories. Some are antidepressants, for example, that are the old-fashioned antidepressants that nobody's using for depression anymore, because at the dose for depression, they have quite a bit of side effects. But for pain, they're used at low dose, and they seem to help with sleep and help with just calming down the nervous system. And then there's other categories like anti-seizure medications that are used as well for that. If you think about, the trigger points of being little seizures in a muscle, and the constant pain being like a little seizure-like activity, and not that it's seizing, you're not moving, but it's in the brain, it's like an abnormal firing of nerves that really shouldn't be firing. So the antidepressant, the anti-seizure medications help calm down that general hyperexcitability of the nervous system. However, they do have a lot of side effects, the anti-seizure especially. So they help with sleep. So if someone's sleep is very disrupted, we will sometimes use those. But you have to kind of taper up and use them with caution, because side effects sometimes can be worse than the pain or the symptoms. Right? Yeah.
I'm like her, only I'm between 12 and 13 years later. So prolapsed uterus, head hysterectomy just made it worse. So I ended up with not just pelvic pain, but it went in with, but now pelvic back, it's shooting down the leg. And so years and years, and have tried regular system, complementary, like I've done it all. So it can go on, hopefully there's no, but it can go on for decades.
Yeah.
Very discouraging.
Yeah, well, I'm sorry to hear about your journey. I think that unfortunately that's what we hear a lot. And some patients are, our average number of years of pain in our clinic patients is 10 years. And we looked at our early outcome data, and we did a follow-up study, and we had significant decrease in pain and mostly improvement in function as well with our interventions. It's not perfect. The pain went from an 8 to a 5, right? And the function went up by 50%. So it's not that you're going to necessarily expect. You have to manage your expectations as well. But our goal is to improve people's function and quality of life. So we don't promise or think that removing the pain necessarily should be the goal. We really think that it's improving quality of life and function. Like, what's a meaningful function for you? And what is it that you can't do now that you want to do? Even if you have pain, can you do this? Can you be able to do, I want to be able to go look after my children or grandchildren. I want to be able to walk to the store and, you know, pick up stuff and be able to cook for myself. I want to go back to work. Like, there's different goals that people have, right? And we try and help them achieve those goals, understanding they may still have pain, but can they function better?
Anyone getting any closer to finding out what the cause of endometriosis is? Like, why me?
Why
What
you?
did I
Yeah.
do? What-
Well, the best understanding we have right now is that it is probably retrograde menstruation, which is when we menstruate, the menstruation comes out through the tubes, but also through the cervix, and most of menstrual blood comes out through the cervix, but some tracks up through the tubes, and that's a normal process. Every woman has that happen to a certain extent. Your body's supposed to recognize those cells and clear them from your body. In endometriosis patients, that doesn't happen. So there's an immune factor there where the immune system that's supposed to recognize those cells is not recognizing the cells and clearing them. So a lot of the work is being done on the immune system, and why is it in some women the immune system is not clearing the cells? And that's where the genetics come in, because the immune system is usually a genetic, predisposition, and could it be environmental effect as well. So if there's more blood, if there's no pregnancies, those kind of things make the likelihood more higher. But we're getting closer. But I mean, there's a lot of work being done, but there's no aha cure right now, unfortunately.
What about the study on fetal autopsy for 10% with endometriosis?
Yeah, so that's a whole other avenue right now where there's a lot of talk about the menstrual, withdrawal at birth of babies and stuff, and whether that's a setup for